We are officially live streaming on Facebook. So I want to welcome back today Dr. Adam Numis and Dr. Hannah Glass from UCSF. I'm Betsy Pilon, the president of Hope for HIE. Thank you all. First and foremost, it's been a wonderful Giving Tuesday. I've had a lot of joy reading people's stories today and looking at the different resources that we provide as an organization. This is one of them that we're really excited and glad that we can provide. So I want to thank everyone for your support, and we'll get right into it. This is our second of 3 of our Q&As. Tonight's topic, or today, depending on where you are, is focused on treatments for infantile spasms. So I would like Dr. Numis and Dr. Glass, if you guys would both give a quick introduction again on yourselves, and then we'll get right into it.
Great. So hi, I'm Dr. Hannah Glass. I'm a child neurologist at UCSF Medical Center and Benioff Children's Hospital, coming to you today from rainy San Francisco. My specialty is in newborn brain injuries. So I see a lot of children with HIE, and then a part of my research program is to understand how to optimize development in children with early brain injuries. So glad to be here. Thank you.
Thank you.
And I'm Dr. Adam Numis. I am a child neurologist as well that works with Dr. Glass at the University of California, San Francisco. My specialty is in epilepsy, and my clinical practice is actually helping to manage children with infantile spasms specifically. And my research focuses on why some children develop epilepsy like infantile spasms and others don't, and also why some people respond to treatments and others don't, and why some of these medications may work in the brain specifically.
Great. Thank you so much again for joining us. So we talked a little bit last night, obviously, for what IS is and who's at risk and how they kind of develop. So why don't we get into how they're treated tonight?
Yeah, so again, thank you for bringing us back. So once infantile spasms are diagnosed, rapid treatment is necessary in order to prevent any long-term sequelae, and we'll get into that in a little bit. The mainstays of therapy are hormonal therapy with or without vigabatrin. Hormonal therapy is either prednisolone, which is a glucocorticoid, or ACTH, which is a peptide, a hormone that our bodies produce. Someone might use either of those with or without a combination of vigabatrin. We don't exactly know how hormonal therapies help to treat spasms, and that's an active area of research that our group and others are looking into. Vigabatrin is a medication that increases the amount of GABA in the brain, and GABA is the major inhibitory neurotransmitter. Now, in thinking, there's been a lot of debate and research to try and understand what the best first medication is to start in a child with newly diagnosed infantile spasms. There's been a number of research studies that help to look at this, but what's been problematic is a lot of these are smaller studies. When you look at a research study done in 2005, one of the larger ones, it included 100 children, and they randomized them between receiving vigabatrin or prednisolone or an equivalent to ACTH. So 2 groups, and they were fairly similar. Initially, the hormonal therapy group did a little bit better than those who received vigabatrin alone, but in the long run, after 12 months, both groups did about the same in terms of who responded and who had any relapses. There have been a number of other smaller studies that maybe include 20, 30 people along the way. And then in 2017, a larger study was published that included about 300 people throughout Europe that looked at comparing combination therapy with either ACTH, an ACTH equivalent, or prednisolone with vigabatrin versus hormonal therapy alone. And in that study, the hormonal therapy group with vigabatrin did a little bit better than the group that received hormonal therapy alone, but it had an increased number of side effects associated with it. So it's a little bit tough to say there's one definite paradigm for any particular person, and this is going to depend a little bit about where you are, what a particular group's practice is, because there isn't just one standard answer just yet. And there's ongoing research to look at this. In the United States, there's a clinical trial that started with Dr. Kelly Knupp at the University of Colorado that's now a multi-center study that's comparing an ACTH equivalent, a synthetic version of it, comparing that to combination therapy or vigabatrin alone. So there's a lot of active work going on to try and understand, again, what is the best drug or drugs to give somebody and what, the long-term sequela of that may be.
All right, great. So we have a question that is very related to what we're talking about right now, coming from Allie Hayes, who says, what is the age cutoff for prednisone and ACTH?
Yeah, so what we were talking about yesterday, infantile spasms typically develop between 3 and 9 months of age and almost always by 2 years of age. If they develop after 2 years of age, it's usually related to another type of genetic etiology, in which case you have to think a little bit differently about the treatment options. But it's a good question. You can use prednisolone or ACTH really at any age. ACTH in the United States is approved up until age 2. After that, it may be tough to get insurance companies to pay for this particular medication, but we've been able to do that in some circumstances. And again, you'll see a lot of discussion about whether prednisolone is the right option to start, ACTH plus or minus vigabatrin, right? So we talked about the combination therapies versus vigabatrin, but even between the types of hormonal therapies, whether you use prednisolone, which is a liquid medication, or ACTH is an injectable medication, so it's usually injected twice a day into the leg, is also an area of debate. And so that's an ongoing area of research. Many programs often use liquid steroids first, but others certainly will use the injectable medications as well. And we'll get into why a little bit later.
Okay, great. So Allie, I'm going to table your next question for a little bit later in the discussion because I think it'll fit better then. But duly noted that you've asked it. So Hannah, why is it important to treat infantile spasms?
Yeah, so Adam alluded to this, and really the goal of treatment is to stop the spasms and to resolve that abnormal EEG. And when the seizures are stopped quickly and the EEG pattern is normalized quickly, this is what gives the child the best chance of advancing in their development. And we know from studies that if there is a prolonged delay in treatment, this can impact the development and slow down development. So the recommendation is really to see a provider that can effectively evaluate a child within 1 week of onset of spasms. We know from some of these studies that actually only about 1/3 of children are seen within 1 week, which is the recommended. And the average time can be 3 or 4 weeks. And in some cases, it's much, much longer. Now, why would this be? Well, sometimes the doctors think it's reflux or they brush it off as really it's nothing, don't be concerned. We know that parents are often the first ones to really suspect that something's wrong. So I'm here to really encourage parents to trust your gut. If you feel like something's wrong, pay attention and advocate. So an effective provider is one that will have had experience with infantile spasms. They'll always be available to carefully review the history and to carefully review a video that you've taken. So taking a video of the events is really a very important thing to do. And by the nature of infantile spasms, because they come in clusters and because they happen multiple times a day, it should be pretty straightforward to take a video with your smartphone, or if you don't have a smartphone, try to borrow one just to be able to take a video. An effective provider should also really be available to consider doing an EEG urgently. An effective provider will at least look at the video, and if they're not 100% sure that these are not spasms, they should be offering to get your child evaluated very soon with a video EEG. And again, urgent treatment within a week of onset is what's recommended to really optimize the treatment of the spasms and to optimize neurodevelopment.
That's really helpful information. I really appreciate your use of effective provider, because obviously that can be tricky depending on where people are located, you know, if there's families in more rural areas, and trying to figure out best ways to, you know, get the care that they need for their child. So I really appreciate that information, especially for our community. So thank you for that and understanding that. So going to the next question for Adam, you know, how long will infantile spasms last?
Yeah, it's a great question. And Dr. Glass alluded to this as well when she was discussing that the whole goal is to stop these as quickly as possible. And in the last question, I talked a little bit about the different treatments, the standard treatments, ACTH or steroids, prednisolone, and or vigabatrin. And while there might be some debate still about which drug or drugs may be the best starting point, what everyone in the field agrees on is that you start medication as quickly as possible and you rapidly evaluate people to see if they're responding. So you don't give it 2 months to see if somebody's responding to these medications to stop their spasms. You do so very quickly, usually within 2 weeks. So, you know, every place will have a different protocol and a different sort of follow-up, but typically what's done is you start a treatment, you give it 2 weeks to see if it's worked or not, and then you move on. So that regardless of what of those standard therapies you're using, whether it be prednisolone, ACTH, vigabatrin, or a combination of them, you're using them, reassessing the child in 2 weeks to ensure that the spasms are entirely gone. If they are, wonderful, you've achieved what you needed to. If not, you move on to the next treatment. So I'll give you an example. At the University of California in San Francisco, we'll typically start children on a combination of prednisolone and vigabatrin after we confirm the diagnosis of infantile spasms with an EEG. We'll bring those children back, usually around day 14, 2 weeks after starting the treatment. If they responded, great. We'll slowly start to come off those steroids, the prednisolone. If not, we'll switch them to ACTH very quickly. And so they'll get that therapy then in combination with vigabatrin. And similarly, if once we start that, we'll bring kids back in 2 weeks after that. And so it's constantly kind of reassessing the patient with their family and trying to ensure that we've stopped these spasms quickly so that we can prevent any long-term neurological problems or difficulties related to it. Again, those are the standard treatments we have with the goal of stopping them. There are alternate treatments. So in children who don't respond to the standard therapies, other medications like valproic acid, zonisamide, topiramate have been used. They're less effective and they have less research with them. I wouldn't consider them our first-line therapies. Therapy that I've had success with is the ketogenic diet for children who do not respond to steroids, ACTH, or vigabatrin. The ketogenic diet has gained a lot of popularity in media. It's a high-fat, low-carbohydrate diet. The treatment when it's used for epilepsy is a lot more restrictive than what you read about or hear about. And you have to do that typically in an epilepsy center that has a dedicated dietitian, because it's an intensive therapy that involves a lot of monitoring. Fortunately, in this age group, there's formulas that are quite easily to administer, which can be very helpful and very successful. Alternatively, there's surgical options for children who don't respond to these therapies. Some children might be candidates where you remove part of the brain if there's a part of the brain that developed differently. In children with hypoxic ischemic encephalopathy, that's not typically the case, but there are other surgical procedures such as corpus callosotomy that can be used in kids who are very refractory, who just don't respond to the medications or treatments we have available.
All right. Very helpful to know that as well. I think in this section, because we're talking about how long infantile spasms might last, I'm going to bring in one of our community questions which is again from my our friend Allie, who says, my son is 5 and still has spasms. What's the best treatment for older kids?
Yeah, great question. Again, so in some kids, these spasms do continue to go on well after the age of 2. It's uncommon, but definitely does happen. And it depends a little bit on what's been trialed already, right? So during that period of development, between 3 months of age and 2 years of age, we know the therapies that are most effective. There's been much less research in kids who are older than that. In cases where kids start with spasms, infantile spasms, and they continue on, medications such as clobazam have been utilized. Other groups have used things like Epidiolex is being studied as well. That would be the prescription version of CBD. But there isn't one particular therapy, and it really depends on what medications have been tried already. Certainly, if steroids or vigabatrin haven't been used, that would be something to utilize. Again, other medications could include valproic acid, topiramate, Felvital. And then if medications have failed, corpus callosotomy is a treatment that is, research had been done several years ago, and there's been more recent studies suggesting that it can actually be quite effective and stop spasms in up to 50% of children who have spasms alone. So there, again, not one particular answer, and this is something where an epileptologist or a child neurologist who specializes in epilepsy would be a good resource to kind of, again, go through what has been tried and what other options might be available.
Great. Thank you for answering that. We have another question from one of our parents, Lisa, who says that her question is for the second round of treatments. Her child's first round was successful and has produced normal EEGs. Does the second round treatment start after individual spasms or after clusters develop? And then secondarily, how many breakthrough spasms are tolerable and how often is second round treatment needed?
Great question. So long term, the response rate for these therapies is typically about 50 to 60% in that range. And that's in kids who have relapses later on. And we really haven't broken that down by particular etiologies. So we still are learning about whether kids with HIE have a higher or less likelihood of having a relapse. When someone does have a relapse, second rounds of medications can often just be the first round. If someone responded to hormonal therapy with or without vigabatrin, we often will try that again, especially if it's been a few months, because kids may need another round of it to be effective. If that relapse happened right away, sometimes we'll do longer courses of ACTH or steroids, or sometimes we'll move on further. So again, this is where we know what the best first set of therapies are. When they relapse, it depends a little bit on when or where they relapsed and how far after the therapy was used. So you can use these therapies again, and sometimes a second round is needed to completely rid a child of them. And other times, if it happened right away, right as soon as we started to wean these medications or come down on the dosages, we'll move on to something else. Again, in our practice, we use the ketogenic diet quite a bit in our patients who have not responded to prednisolone, ACTH, or vigabatrin, but different places will have different sets of practices. In terms of how many you want to tolerate, the answer is 0. So I kind of think as infantile spasms as a 0 or 1 or binary kind of thing. You have them or you don't have them. So we're really looking for seizure freedom here because we know that spasms are associated with that abnormal brain activity we talked about yesterday, or hypsarrhythmia, especially if they're ongoing longer and longer. So as long as you're getting close follow-up and making sure that pattern isn't veering its head back, it's important, and it may help guide therapy a little bit as well.
All right. Very helpful information. Thank you. So we have another question of, can you explain again about the surgery, the corpus callosum?
Callosotomy, yeah.
Thank you. There we go. As this is something that this mom said she's failed all drugs and have the VNS epileptics, and she said they're the rare breed and have been dealing with IS since her child was 6 months old and is now 9 years old.
Yeah, so, and this is something that would be good to bring up with your epileptologist. So corpus callosotomies are surgeries that were done more frequently in the over a decade ago, but there was a recent study that came out of Japan where they had over 50 children with very tough to treat infantile spasms, similar to your child, where medications were just not working. And they did this procedure, which essentially disconnects the two hemispheres of the brain. So the right side and the left side are disconnected. And why this works, we don't entirely understand, but in their hands, about half of the kids with epileptic spasms alone had basically total resolution of their seizures. If kids had other seizure types, this surgery really was helpful for the spasms, not necessarily the other seizure types. And again, it's a disconnection procedure. It does have its own set of side effects, but it's not where you're essentially taking a part of the brain out. You're really just disconnecting the two sides. So it does involve an approach that includes an epileptologist, a neurosurgeon. And again, the hospital stay itself can last a few days to over a week, related to some of the side effects associated with that surgery.
Sure. Thank you for answering that. It looks like we have another question too, and this is from Lisa Ledson, who is actually a representative for the Infantile Spasms Action Network. So Lisa asks, once spasms are controlled, is there a recommended AED to use long term?
Great question. In many kids where we don't know the cause, we actually will come off all medications. So the best case scenario is kids don't need long-term therapies. Again, infantile spasms occur in this unique developmental window, and as the brain matures, kids can outgrow them. In kids with HIE, they're still at risk for other seizure types as well. But in my practice, I don't use a long-standing anti-epileptic drug unless a child's body is telling us it needs it. So unless other seizure types are emerging or come out, our goal is to use these therapies to stop the spasms, and then ideally get the children off of the drugs and then let their bodies let us know if they need additional medications for other seizure types. In our practice, again, we'll bring kids back to watch to make sure that the spasms have resolved, and then we'll wean the steroids over weeks. I often will keep children on vigabatrin for a longer period of time, but not longer than a few months, up to 6 months. And again, that's that period where relapses tend to occur.
Gotcha. Very helpful. Thank you for answering those questions. So I know, Hannah, we want to talk about, the mnemonic a little bit, and what if someone suspects infantile spasms, what they should do and what that looks like.
Yeah, so I'm going to screen share again. So hopefully those of you watching at home can see this coming to us from the Child Neurology Foundation. So again, the most important thing is to recognize what's happening, take a video, and find an effective provider. And so we can use the acronym STOP. And S stands for see the signs. So what you're looking for is a cluster of sudden, repeated, uncontrolled movements where the head bobs or the body crunches or sometimes the arms extend. T is for take a video, record the symptoms and provide the video and talk to your doctor immediately. O is to obtain a diagnosis, so confirming the irregular brainwave pattern that we call hypsarrhythmia with an EEG test. And then P is prioritizing treatment, ending spasms to minimize developmental delays. And again, we recommend that a child be diagnosed and treated, if possible, within a week of onset of the spasms.
Thank you for that. One question I had when we were talking about treatments, we have a lot of families that talk about, they'll go in and the hypsarrhythmia is not found the first few times they have an EEG. But then, if they've waited for treatment, then sometimes it does start to show up. So what is some advice that you would give to those parents that are, they're trusting their gut, they're seeing the signs, they're taking the videos, but when they're going in, it's kind of this waiting game, and they're being told that, we talked a little bit about it yesterday, and that that's like catching it early, which is really good, right? But what advice would you give in that situation?
Yeah, you don't need hypsarrhythmia to treat with these medications. And again, the whole point is getting kids in earlier because the effectiveness of these medications is higher. We know that the quicker children come in for therapy, the better chance they have of actually responding to the medications. So in our practice, we don't wait for hypsarrhythmia to start these treatments because we're not waiting for someone to fall off of a cliff. We want to be proactive and really help give children the best chance to respond to these therapies. So we're not looking to wait until hypsarrhythmia occurs, or we're taking everything in context. So if someone has infantile spasms, we'll treat them accordingly with these therapies that we discussed.
Great. Thank you so much for that. Here's a great question too, and I think this will probably be our last one because we're running out of time, but from Lisa, what terminology can parents use with medical professionals who may not have awareness of IS?
That's a good question. I think just saying I'm worried my child might have infantile spasms. And I think that that's a really good start. So a medical provider who's not familiar will probably go to the literature or to the websites and do some research. So using that exact terminology of saying, I'm worried they might have infantile spasms. I'd like to show you a video. And, you know, what I understand is that this needs urgent treatment. Those are some key words that I would use.
That's really helpful advice. Thank you so much for that. Great. Well, we're wrapping up day 2 of this Q&A. I want to thank you both again for joining us and everyone who's watching. We've had a lot of people and a lot of engagement today. Thank you so much for coming on, and hope that this is helpful for everyone. We do have, we're going to post some information in the comments as well about other, resources out there that we can share. And we are going to have one more session that's going to be on what's next with research and things like that with IS on Thursday. So look for that, and we'll share out that event as well. So again, Adam, Hannah, thank you again so much for being on today and sharing your expertise with our community. We really appreciate it. And to everyone who's watching, thanks again. All right, we'll see you Thursday.
Great. Thanks, Betsy.
Thank you.
Take care.
Bye, everyone.